Alright, this is a spinal insertion, and Charles will demonstrate for us the technique we were taught by Laura. So, it's on you.
Well, if I recall properly, I probably don't. We want to start by letting the patient know who we are. Hi, I'm Chuck. I'm a nurse anesthetist at this point, and going to be placing a spinal catheter in your back there for pain control. One of the first things we want to do is make sure they don't have any contraindications, such as coagulopathy. We want to make sure their platelets are adequate. We want to make sure that their INR is not too high, and institution don't have specific parameters. So once we've actually talked to them, we want to find a landmark. Let's see, check their hip over here, coming straight across from their hip. I can feel. There we are. Display this process straight across. It's a little too short. Actually looking at all four, and I'm planning on going to L4, L5 interspace, between L4 and L5. We're going to go here, and I'm going to use my nail and make a bit of a mark so I can come back to it later and see where it is I want to go. I've already washed my hands. I'm going to find myself a spinal tray. This is a spinal needle tray. On the back we have a list of what's in it. We want to assess that it has the medication that we want to use based on the duration of our procedure and such. We want to make sure that we're going to use an appropriate local anesthetic. And if we want to add any sort of narcotic for additional analgesia, we'll go get that, whether it comes from the pick sticks or from a lockbox, or if it needs to come straight from the pharmacy. We actually have a list here. Okay, now for this procedure, I've chosen the 0.75% bupivacaine. It's 7.5 milligrams per cc. And my desired block is going to be a T10 level, sensory block. So we're going to go with 1 cc of that. That's my plan. So I don't need any additional narcotic. So we want to open up our kit. Please stop it. I got the problems here.
Yeah.
We want to open up our kit and find ourselves a space. Now, I probably would have been standing, checking the patient. I didn't mention, but I have them come toward the edge of their beds they're sitting on, or the stretcher they're sitting on. I have them bend over in the scared or the angry cat position with the back bent pretty far forward to open up the interspaces pretty well. At this point, it would be okay for me to sit down or get to a comfortable level. So, have I already gowned up?
Yeah.
Gowning or depending on the institution, some places you gown. I've probably been wearing my mask in the head since we started.
Right.
I've got my gloves on at this point, sterile gloves. So we're going to see what we've got in here. We just got a little drape here to put under the bottom. Just asking, hey, can you lift up just a little bit? You lift up a little bit. Keep that right on. Make sure that I didn't contaminate anything such as my hands. We take out our little kit to clean up the back. Pop open our PI solution, squirt it in the bin here, throw this in the trash. Now we're going to take our swabs, stick them right in, cleanse the area, start the insert going out. Put one. And you'll notice it's going to be cold. I probably should have warned them beforehand. It's going to be cold, wet, and it may actually give you a bit of a tingling or crunchy sensation there. Then the third one, I'm going to hold on to my gauze. I'm probably going to leave that in just a little bit. Now at this point, I'm going to get the rest of my kit ready. So the first part there that I've already used would have come set up on the top. But at this point, I'm opening up the rest. Now, fortunately, this time, I do have a little bit of a work surface here. I'm not always guaranteed that, but at least I can set out my drugs here that I need. Here's 1% lidocaine. I'll be using that for my local anesthetic at the skin site. I don't need my dextrose. I don't need to set up a hyperbaric solution. I'm not going to be using the tetracaine, nor will I be using the 5% lidocaine. I don't need the Epi 1 to 1000. Here's one. Bupivacaine specifically says for spinal. It's kind of heavy. It is a 0.75%. We're going to get our bullet down. Open the top. Have that ready to go. These are the two drugs that we're going to use. Lidocaine for local, and I'll open the top as well. Next thing I'm going to do is take my 3cc syringe. This will be for local anesthetic. believe I cut a 22 gauge needle on there, just to make it a little easier to draw it up. I'm going to switch to a larger needle with my 18 gauge, excuse me, 20 gauge. So I pop off the top of the lidocaine, drop my 3 cc's of local anesthetic, then we're going to switch to my 22 gauge needle for the local infiltration. So that'll be my first thing. That's going to be set up on my little work surface, hopefully. The second thing will be the introducer. I see that my needle looks okay, no burrs or anything like that I need to worry about. We have the spinal needle. It's good. It's not too bent despite the fact that Patrick used it. It's unusual. And here we actually have some places to have a glass syringe. With that syringe, it will be for my local anesthetic. I'm going to put on my filter straw, or use a filter needle, whichever one's available. And we're going to drop the bupivacaine. And I'm going to drop 1 cc. And I've got a little bit of, I want to make sure I have a little room in the syringe regardless. And hopefully I won't lose anything here. And at this point, I can still see the mark where I made it my thumbnail. I'm going to let the patient know this is the point from here on. It's very important that they don't move. And they'll be standing. Either way, we can open up my face. I really don't want to stand there. I don't want this to fall off my little surface and everything. Make sure that my fenestration is going to land right where I need it to. Surgery. Patient now. Just getting ready to start here. I'm going to take the gauze that I set aside. We'll make sure we don't have any chance of chemical meningitis. We'll make sure that everything is totally dry. Let the patient know we're getting closer to the injection. I have my local anesthetic, my 22 gauge syringe, and I put probably about 3 cc's of my 1% light over there. And I can still see where I made my mark with my thumb. Of course, I really can't now. I'm going to confirm my interspace again. Okay, so my markers here. We'll start with just a little skin wheel. You can notice a bit of a pinch. Could be a bit of a burn with the local anesthetic. But a cc could go at the skin level. And then as I advance the needle deeper. So we did our cc at the skin level, and then we'll give the rest as we advance the needle further in. And for most people, we can go pretty much to the full depth of the needle. At this point, I can set that needle aside, syringe, and let's give our local anesthetic a few cc's to work. As I say, since I haven't actually been able to see my mark here, I'm going to confirm my position. And get ready. We're going to bevel up. We're going in slightly cephalad. Alright, we can go in. We'll definitely introduce her. Prepare my actual spinal needle. We'll go in. Meeting a little bit of resistance. We can come out and reposition a little bit. Really doing better the first time. Okay. I'm going to make sure that I fix it. So it comes neither forward nor back. We're going to wait for watch for return of CSF. And we do have return of CSF. I'm just taking the filter off my anesthetic syringe, making sure I keep it fixed with the other hand, and then I inject my cc of medication. After I pulled back just a little and watched for the swirl of CSF in the syringe, and after I've injected, as a unit, I'm going to pull out needle and introducer. We're finished with that. Put the brush sharps where they need to go. We take the drape off, tell the patient that they're finished with the injection. I want to lie them down. I want to watch for signs of hypertension. Any other problems? Certainly, toxicity from vagina would be a good idea. shortly thereafter, we'll be able to finish him for surgery.
Hey Chuck, blood pressure just dropped to 70/60, heart rate's 35. Dude, I think you did something wrong.
You think so?